I am going to hand this over to Barbara Hanning, who is with Greenwich Biosciences, and she's going to introduce the speaker. Thank you.
Thank you, Francine, and good evening. I'm Barb Hanning from Greenwich Biosciences. Greenwich Biosciences is thrilled to support the work of the Epilepsy Association of Western and Central Pennsylvania and join in their effort to help people with epilepsy live life without compromise. So I'm proud to have the opportunity this evening to introduce Dr. James Valeriano. Dr. Valeriano is chairman of the Department of Neurology at Allegheny General Hospital in Pittsburgh, where he's also the director of the Comprehensive Epilepsy Center. He's on the board of directors at the Epilepsy Association of Western and Central Pennsylvania, and he has published numerous research articles and book chapters on various topics related to the treatment of epilepsy. He received his Bachelor of Arts from the University of Pennsylvania in Philadelphia and his medical degree from the University of Pittsburgh. He now, Dr. Valeriano did his internship at Thomas Jefferson University Medical Center in Philadelphia and his residency at Georgetown University Medical Center in Washington, D.C., where he also completed a fellowship in clinical neurophysiology. So Dr. Valeriano, thank you for all you do for patients affected by epilepsy and for being with us today.
Okay, thank you. And again, my sincere apologies for the delay. So basically, we're going to talk about some of the basic things about epilepsy, but mainly we're going to talk about the medication. So go ahead. Let me get. All right, so epilepsy, what's the definition of epilepsy? So the International League Against Epilepsy, which is like the governing body of epilepsy, essentially it's 2 unprovoked seizures. Meaning unprovoked means if you would be up all night and drinking caffeine and had a seizure in the morning, that would be considered a provoked seizure. So unprovoked seizures, it's sort of a funny way to put it. You can have had a stroke and have a seizure. That's still considered, if it's not right with the event, the acute event of a stroke, if you had a seizure right then, that would be considered a provoked seizure. If you had a seizure 2 months later, that's an unprovoked seizure. The idea is there's some condition that's not an acute condition that causes the seizures. Historically, 2 seizures were called epilepsy. Now, epilepsy can also be called 1 seizure with a condition that increases the odds of recurrence equal to that if you had 2 seizures. In other words, if somebody, God forbid, did have a brain tumor and had 1 seizure, because of that tumor, their risk of having a second seizure would be at least as high as somebody who didn't have something like that and had 2 seizures. So the definition of epilepsy has changed a little bit. By and large, it is still the working definition is still more 2 unprovoked seizures. Okay? So epilepsy is a common disorder. More than 3 million Americans of all ages are living with epilepsy. Each year, 200,000 new people are diagnosed with epilepsy. One misconception people have is that epilepsy only starts in early life. It can happen at any age. The peak of the new onsets are before the age of 15, and believe it or not, then after the age of 60. Between 15 and 60, you can still develop epilepsy. There's sort of a low incidence of new onset, but definitely it can happen. And then it starts to trend upward again, the new onset of epilepsy after the age of 60. Next. Epilepsy can be defined as idiopathic. That means we don't know why people have it. So people, I always tell people everybody says, geez, why did this happen to me? And I always say to people, there's 2 kinds of people that have epilepsy. One is that we know why they have it, and one we don't know why they have it. Most of the time, you're better off being we don't know why you have it, because normally if we know why you have it, it's not a good reason. So that's usually it's called symptomatic epilepsy, when we know why you have it. So it's epilepsy for which an underlying cause has been identified. And what this says is usually an injury or structural abnormality of the brain. Again, so someone's had a head injury. They've had a history of meningitis. They've had a history of a stroke. They've had a history of a tumor. Something's happened to the brain, and one of the symptoms of that brain injury is epilepsy. In the idiopathic type, that means we can't find out why you have it. Cryptogenic just means that we assume that there's probably a cause for it. It's, again, somebody that's 60 years old and has a new onset seizure. It's probably caused by something symptomatic, but maybe something that we can't tell from scans. It may be mild cerebral vascular disease. Sometimes just aging of the brain can really lead to seizures. That's why we think that people over 60, again, can develop epilepsy. Next. So seizure types, just because this is going to tie into the medicines. So there's partial seizures that originate in one specific area of the brain, and then where the seizures would start in that brain is how the seizure plays out. So there's parts of the brain, in other words, that controls your movements of your right arm, the left motor part of the brain. If there's a seizure discharge, if there's an electrical irritation there and makes those cells begin to fire, your right arm would start to twitch. So that would be a partial seizure. It starts in one part of the brain, and we can tell what part of the brain it starts in usually by what happens to the person with the seizure. A generalized seizure means the seizure starts in both hemispheres at once. So this older term would be a grand mal seizure, now sometimes called a generalized tonic-clonic seizure. So these are larger seizures. A seizure can start in one part of the brain and spread to become generalized. So you can have a seizure that starts with your right arm twitching, and then after 30 seconds, 60 seconds, you go into a generalized seizure. So partial seizures can become generalized seizures. Next. Simple partial seizures means that the seizures affect a part of the brain but don't cause a change in consciousness. Again, if your right arm and right face twitch, but you maintain consciousness, that's called a simple partial seizure. A newer term is focal onset awareness seizures. It means the same thing. Complex partial means that there's an alteration of consciousness. So people lose awareness. They don't remember what happens during that time. A new term is focal onset impaired awareness, but the point is it starts in one part of the brain. This is where people have a blank stare. They may smack their lips. They may just do little picking movements, but they're not aware of what happens, and they're amnestic for it. They don't remember what happened. So there's an alteration of consciousness. One of the issues, if that kind of seizure, if that goes on for a while, over time, people can end up with permanent memory problems with complex partial seizures because the memory banks tend to get affected with that seizure. Either type of seizure begin as a partial seizure, so again, what we talked about, and can spread into a generalized seizure, okay? So one thing, again, just to remember, so sometimes when you talk to the doctor, and this is just sort of going through sort of a general thing, a lot of times, especially people that are well controlled, why do you have one seizure a year? Why do you have 3 seizures a year? Why just on those 3 days? So there are people that have very difficult to control epilepsy, but even in those people, there can be things that bring it out. And in people that have very rare seizures, there often is something that brings it out. So what things can cause this? Missing a dose of medication. That's the most common cause of a breakthrough seizure in people who are well controlled. Sleep deprivation. Increased stress level, that often goes along with sleep deprivation. Alcohol excess, especially the alcohol withdrawal state. So a hangover. Hangover is irritating to the brain. That's why light and sound bother people when they have a hangover from alcohol. The brain becomes irritable. It becomes electrically excitable. So heavy drinking can do it. Certainly stimulant drugs such as cocaine. Very rarely, there are people, though, that have flickering lights that can do it. And some people can have cannot have pinpoint triggers, but the ones above are typical ones. But if there's something that you seem to happen to you where you say, geez, it seems when such and such happens, the other thing, like in a woman, their menses may be a time they have it. So if there's something where you say there seems to be a common denominator when I have the seizures, note that and let the doctor know. Next. So the ultimate goal is seizure freedom with minimal side effects. Now that's the best you can do. And that's sort of always is our goal, seizure freedom with as little side effects on the medicines as possible. Some people that may not be attainable, but that's what we try to do. So what's the advantage of this? Obviously, what are the advantages of seizure freedom? You might be able to get your driving privileges back. It may make you be able to get a job back, job stability if people are still in school, academic success. And one thing to talk about with the doctor, it's reasonable. What are your goals? What is it are you looking to be? Most people are looking to be entirely seizure-free, but you want to be seizure-free with minimal side effects of medicine. So it's important to talk over the doctor. You go into the doctor and you have 1 seizure a month, and he or she says, well, that's not too bad. It's 1 seizure a month. You can say, look, I don't want to have 1 seizure a month. I'm willing to do something differently because with 1 seizure a month, I still can't drive. I can't get a job. So again, you need to make it clear what your goal is, okay? So what happens in a seizure? Basically, a seizure, nerve cells become overexcited, and these are electrical discharges. So one nerve cell sort of signals to another, basically literally an electrical current. And as that current spreads to more and more cells in the brain, nerve cells, neurons, then after a period of time, when a certain amount of cells become involved, then you start to get symptoms. You start to twitch, you start to become unresponsive, poorly responsive, or if enough cells, you have a grand mal seizure. So these are electrical phenomenon where electrical currents that are generated by nerve cells spread to adjacent nerve cells to excite them. And then if enough of those cells become recruited, you can become symptomatic. In other words, that leads to a seizure, okay? And how do the drugs work? Anti-epileptic drugs. So basically what you can do is there's an excitatory input from one neuron to the next. So you can try to decrease the excitation. You can the original nerve cell, you can try to make that less excitable. Some of the medicines work like that to try to decrease excitation, the excitatory state of the first neuron. Other medicines work by trying to inhibit the sort of receptor neuron. So when the electrical signal goes from the first neuron to the second to excite that, another way drugs can work is to try to inhibit that second neuron from accepting the excitatory input. So you can try to decrease excitation or you can try to increase inhibition. Both of the ideas, you're trying to damp down excitatory or excess electrical signals that cause seizures, okay? So what we wanted to talk about was some of the medications in general. And one of the things that Francine mentioned was that people would be interested in medical marijuana because that's a big topic. So I'm going to start with the state of Pennsylvania's medical marijuana program. How this works is that if you look at the third bullet, a patient goes to a website that's medicalmarijuana.pa.gov. On that website, you register. So that's the fourth bullet. You obtain a registration card with a registration number. I think the cost of that registration card is $30 to $40. When you get that registration card, then you then get in touch with your physician, and the physician then registers you through the web. So that's the next bullet. Physician registers patient through the web. And so the doctor does not actually prescribe the medication, the medical marijuana. What the doctor says is that you're eligible to get medical marijuana because you have a condition that allows you to get it through the state of Pennsylvania. One of those conditions is seizures. So people that have epilepsy are eligible if you can get a doctor to say that. So the doctor you get your registration card with your number through that medicalmarijuana.pa.gov website. You then give the registration number to the physician. Then he or she goes on that same website and puts in your number, your registration number, your name, your birth date, that type of thing. And then there's some questions for the physician. What makes this patient eligible? What product do you think that they should get? And the physician then sends that to the state. When the state gets that, they then send the patient a certification card. So you get a card that looks like a driver's license. That card is what you actually take to the dispensary. So it's a couple steps. You register, get a registration number. You give that to the physician who agrees that they're going to do that, they're willing to do this. The physician sends in the registration number. You then get a certification. When you get that certification card, you then go to the dispensary. The dispensaries are also listed on that medicalmarijuana.pa.gov website. That's actually a pretty good website. It really does work well. So if you don't know where one of the marijuana dispensaries is in your area, they're all listed on that website. When you go there, you will consult with a pharmacist, and he or she is somebody that specializes in the medical marijuana products. And so they will go over, there's different products as far as how much CBD's in it and THC. I think one of the next slides shows that. We'll get to that. And so you talk about, he or she looks at why you're getting this. There's people that go for chronic pain. There's people that go for anxiety. There's people that go for seizures. And the mixture of THC to CBD will be different. Again, I'll get to that, I think, on the next slide. Two other things to remember. The medical marijuana is not FDA approved, so it's the medical marijuana through the state. So it's not an FDA approved medicine. It's not federally approved. So one thing to be sure, if you have this with you, and you make sure you have your card with you, because theoretically it's federally illegal to have that with you because it's not FDA approved. Now, local police are not going to stop you likely, but if they did, it still would be, make sure if you have any of that product with you, you keep your certification card. The other thing to remember is that the insurance does not cover the state of Pennsylvania's medical marijuana. So you have to pay out of pocket. The prices, from what I've heard, vary. It depends also on the dose of what you're getting. And my understanding, it's somewhere usually from $30 to $60 to $70 a month. So it's not cheap. It's not overly expensive, but it's not cheap. And again, your insurance will not cover it because it's not FDA approved. Okay, next. So the state of Pennsylvania medical marijuana contains a ratio of CBD, which is cannabidiol, and THC, which is tetrahydrocannabinol. Now the THC is what people get when they smoke marijuana. So the THC it gives you more of a high or a buzz, whatever you want to call it. That's the main ingredient in what you would buy in marijuana in the street. When you go to get your medical marijuana from the state, what we consider, so if we put down that we're seeing you because of seizures, the evidence really is that what works for seizures is the CBD part of it, the cannabidiol, that the CBD is much more effective than the THC for seizure disorders. The THC seems to have more effect on pain syndromes or in anxiety, and those are two things that people can get the card for. So you need to discuss when you go with the pharmacist, this is why I'm getting it, I'm getting it for seizures. And then the pharmacist discusses there's ratios of these two. If it's for seizures, you would like the ratio to be weighted heavily towards the CBD. There's also different ways there's deliveries of it. There's vapes of it, there's oils, there's edibles, and you can talk that over with the pharmacist. One problem with the state's medical marijuana is it's difficult at times to calculate how much CBD people actually get, because it'll tell you how much to take in milliliters, but they don't often in the bottle that you get give a concentration. There's so many milligrams of CBD and so many milliliters, so it's difficult to tell how much you get. But just to keep this number in mind, it's about 20 to 40 milligrams a day of CBD, of cannabidiol, that you get from the state's medical marijuana program. That's about, it seems to me, the average. But sometimes it's very difficult to get an exact number because they don't give you a concentration all the time. Next. So the medical marijuana that's FDA approved is a medicine called Epidiolex, Epidiolex CBD. Now this is 100% CBD oil. So this is no THC in it. So this usually will not have a problem with giving people sort of a high from it because the CBD part doesn't do that. Fortunately, right now, for you to get this from your insurance company, there's two specific syndromes that you can get this in. One is called Lennox-Gastaut syndrome, and one is called Dravet syndrome. These are very significant epilepsy syndromes that begin in childhood, usually early childhood, and have multiple seizure types, especially Lennox-Gastaut, are very difficult to control. Both of these are very difficult to control. And for right now, that's where the only two things that the insurance will pay for. Now, it may be as time goes on that loosens up, and I'll talk about another medicine later where that's happened. But again, we talked about before with the state CBD, that you're getting 20 to 40 milligrams of CBD with that. If you look at the studies that were done with Epidiolex, the dosages were 10 to 20 milligrams per kilogram of body weight. So if you take somebody that weighs 150, 160 pounds, let's say they're 70 they weigh that's 70 kilograms. So that person would be getting 700 to 1,400 milligrams of CBD a day with Epidiolex. With the state's medical marijuana, again, you're probably getting 20 to 40 milligrams a day. So the dosages that you're getting from the state are much less than you're getting with this FDA-approved medical marijuana. Hopefully, as time goes, the insurance companies will loosen this up, and we can. And right now, I should also mention it's also approved for tuberous sclerosis. This is an older slide. There's also a condition called tuberous sclerosis where people often have seizures with that, and this drug is approved for tuberous sclerosis. So it's now approved for three things. The most common side effects of the drug are you can get sleepy with it. It's an oil. So if you remember, those of us that are old enough remember old cod liver oil. So it's like a lubricant. You can get diarrhea, and that happens more often as the dose goes up because you're getting more and more oil. There can also be balance problems. In other words, a little bit of gait difficulty. A medicine that we'll talk about in a little while called Onfi or clobazam is the generic of it. A lot of people with Lennox-Gastaut and/or Dravet syndrome are on Onfi. It's an effective drug for that. This medicine will substantially raise Onfi levels. It may raise it by 1/3. So normally if you're on Onfi and you start the Epidiolex, a lot of times you'll have to cut back on the Onfi because because the Onfi, the big side effect is sleepiness or sedation also. The one thing to watch for in laboratory tests for the physician to watch is liver functions. There can be liver functions abnormalities with the drug. This seems to happen most particularly in patients who are also in Depakote. Depakote's also called Valproate or valproic acid. So it's something that needs to be monitored fairly frequently, your liver functions. If they do go up, you can cut back on the Epidiolex, you can cut back on the Depakote. But again, Depakote is a fairly common medicine to use in these syndromes, Lennox-Gastaut and Dravet's. For the state's medical marijuana, as long as you have any type of epilepsy, you're eligible to get that. But again, the insurance does not cover it. So this is for this medication, the Epidiolex, the FDA approved, your insurance will only cover it for the 3 syndromes, Lennox-Gastaut, Dravet's, and tuberous sclerosis. Next. So there's a tremendous amount of medicines. I didn't want to go over every medicine, but I did want to mention ones that are common. This is Keppra, and most people will get the generic called levetiracetam. Right now, this is the most commonly used anti-epileptic drug in the United States. For decades, the most common one was phenytoin, Dilantin. Well, this has now surpassed Dilantin in how many people are on it. There's a couple reasons why. The drug is very easy to use. Usually, the dose where you stop for the first time is usually 500 milligrams twice daily. So normally the drug is given as 250 milligrams twice daily for a week, and then 1 week later you go to 500 twice daily, and that you're at a maintenance dose there. So in about a week, you can get up to a therapeutic dose. There's no drug interactions with the drug. So the drug does not affect any other medicines. No other medicines affect this. One of the biggest differences in the older medicines like Dilantin and Tegretol and phenobarbital, they had a lot of drug interactions. They affected other medications levels. Sometimes they could make them go up. Sometimes they could make them go down. So this has no drug interactions. It's also entirely excreted by your kidney. So people that have liver problems, it won't affect the metabolism of this drug. There's no liver metabolism. That's another advantage of the drug. So it's renally excreted. So the doctors like it because it's a safe drug. It does not have significant organ toxicity, so liver, bone marrow, that type of stuff. And it's easy to get on board. The most common side effect, though, is irritability, and that's not rare. The book says 5% of people become irritable. That's probably an underestimate. It could be more like 10% of people. A lot of times the patient or the person themselves doesn't recognize it. The person that lives with them recognizes it and said, geez, I mean, what happened to them? They used to be a nice person. Now, they're horrible to live with. So it's something to watch for irritability. The most common reason we have to stop Keppra is irritability. A new medicine came out a couple years ago, maybe 3 years ago. If you look at Keppra, the name's levetiracetam. This medicine, Briviact, is breviracetam. So this is like son of Keppra. This is a molecule that's very similar to Keppra. One of the advantages of this medicine is you start at 50 milligrams twice daily, and that's your maintenance dose. So you're on a therapeutic level probably by the morning of the second morning you're on this. It has less it seems that what we do sometimes is the Keppra really works well, but people are irritable. This is a reasonable medicine to try to switch to, because if the Keppra worked, the likelihood is this medicine will work because it's so similar structurally. The drug itself, the molecule itself is very similar, but it seems to have less of the irritability in Keppra, somewhat less of the psychological side effects. So this is getting to be a more popular drug. Again, you could say, well, if that's true, why don't you just go to this drug first? The reason is, again, there's a lot of in real life, it's insurance issues. So they would almost always insist, the insurance companies I'm talking about, that you try Keppra first because there's a generic for Keppra. Briviact does not have a generic at this point. Next. And Depakotel Valproate, again, the reason I'm bringing this up because it's a drug that's used very often. For those of you that have children with epilepsy, this is a common drug that's used in absence seizures. So absence seizures are seizures that usually begin, there's two onsets. They usually begin about 6 or 7 years of age. That's childhood absence, or around 12 to 14. That's juvenile absence. These are little blank out spells. The kids blank out literally for 5 seconds, 3 seconds, 6 seconds, and they don't realize it happens. So a lot of times this is seen by other people, and they think the kids are daydreaming, or they just aren't paying attention. So sometimes teachers will bring this up. Depakote's the most effective medicine for this. The other I didn't put in, the other effective medicine is a medicine called lacosamide or Zerontin. That's also very effective for absence seizures. But Depakote also can be used for other types of seizures, and it's used a fair amount in adults for other types of seizures. It can be used in generalized seizures or less commonly in partial seizures. So it seems to have a decent effect on grand mal seizures, generalized seizures. We don't use it quite as much for partial seizures, but it's a fairly commonly used drug. Most common side effects, there can be weight gain, and sometimes there can be significant weight gain with the drug. Also, there can be hair loss. That's not usually too bad, but that can happen. Weight gain is probably the reason why Depakote stopped the most often. Also, as the doses go up, you can get a tremor with the drug. It'll look like it's a tremor, like you were over-caffeinated, a very fine tremor. And that's dose-related. So if that happens, and you back off in the dose, a lot of times the tremor will go away. Again, like a lot of drugs, and well, I can stress this now, one thing, whenever you are put on an anticonvulsant, a lot of the anticonvulsants have drug interactions with other anticonvulsants. So just make sure the doctor knows what other seizure medicines you're on, because there may be significant effect. For instance, with this drug, if you look at Lamictal, lamotrigine, this drug triples the half-life of Lamictal. In other words, this will increase Lamictal almost by 3 times. So you really want to be careful if you are adding this to Lamictal, or if you're on Depakote and Lamictal and they take the Depakote off, your Lamictal level will drop substantially. There's also a medicine called Banzell, another name is rufinimide. That's also used in a lot of these childhood epilepsies. And the Depakote will increase the Banzell levels by probably 25, 30%. So again, just to point out, drug interactions are not uncommon among seizure medicines. And going back, that's one of the reasons Keppra is very popular, because there isn't any. Okay, next. Fycompa, what I was trying to do, not to go over every medicine, but try to get to some of the new medicines too. So Fycompa, the other name is perampanel. But that's a generic. There is no generic, so it's all Fycompa. This is a very potent medication and works very well on a lot of people. So this can be used for generalized or partial seizures. It seems to be particularly good for a lot of the generalized seizures, the grand mal seizures. But it also is effective for partial seizures. One of the advantages is it's a once-a-day medicine. It has a long half-life, so the drug stays in your system a long time. So normally you take it once a day. The most common side effects are sedation, and so usually this drug is given at night. So it's usually given a half hour before bed or an hour before bed. That way, when the drug peaks in your system, which is like in 90 minutes or so, you'll be in bed or either asleep or at least in bed. So if you do get sedated, that's fine. It's not going to bother, it may help you sleep even. There can be behavioral changes with this drug. Now that's true of a lot of the drugs. But sometimes some of the reported behavioral changes with Fycompa can be somewhat severe, where people do get really belligerent, can get more aggressive. Again, this is not a common thing, but it's been reported. So it's something to watch for. One thing, and the dose range is 4 to 12 milligrams per day, just so I don't forget to mention this. So today we were talking about, with one of the residents, about a patient who had been put on Banzell a couple years ago and developed extremely severe acne with it. And eventually the acne went away when the Banzell was stopped. Now that's not listed anywhere as a side effect of Banzell. But the point that I made to the residents is when you tell people side effects and you list them, so say sedation and behavioral changes with Fycompa, make sure people, and this is for the patients, if there's anything different when you start the medicine and are on the medicine that's different and it's bad, that you don't like it, you need to let the physician know. Sometimes don't get the idea that the only side effects that are listed, that you were warned of, that those are the only side effects that can happen. Because there's a lot of different side effects, and sometimes side effects can really be peculiar to one person. One person can get an unusual side effect that a lot of people don't get. or a very rare side effect. So the doctors a lot of times will say, here's the main side effects, here's the worst side effects, here's the most common, but that doesn't mean if something else happens that you don't like, that you think is bad, and you say, well, no, the doctor didn't mention such and such, so that mustn't be from the medicine. If it's different since you started the medicine, you need to let the physician know, even if that's not what the physician pointed out as a potential side effect, because it still could be a side effect that's an unusual one, or even maybe just peculiar to you, okay? This is, again, and I'm sorry to sort of dwell on the Lennox-Gastaut syndrome, but I did want to bring it up for this reason. So Onfi, the other name is clobazam. Onfi came out a couple years ago and proved to be extremely effective in this very difficult to control seizure disorder called Lennox-Gastaut, also was okayed for Dravet's disease. But as time went on, the insurance companies loosened up, and you can now get Onfi even for partial seizures. So the same thing may or may not happen with Epidiolex. So Onfi initially, the only people that were getting it were people with these very severe epilepsy syndrome, Lennox-Gastaut. Now there's people on it that for more kind of garden variety epilepsy, the usual dosing range is actually in adults more 20 to 40 milligrams daily, although some people I have as low as 10 milligrams. This is a medicine that's a benzodiazepine, which means it's in the family of medicines like Valium, Ativan, Xanax. They're all what are called benzodiazepines, and so the common side effects of that family of medicine are sedation, and that's true of this medicine. So this medicine can be very sedating, and sometimes it'll wear off, and sometimes it won't. But you may find out, like today, I did start a woman on Onfi who has just partial seizures. She has partial motor seizures where she just gets right arm twitching and right face twitching. Years ago, we would not have been able to get that medicine for her. Plus, we wouldn't have thought it worked that well for partial seizures, but because the insurance companies now will pick it up for other reasons, we've expanded the use of it. So that's not an unusual. I'm just using this as an example that sometimes as time goes by, medicines that are approved for certain conditions, they may liberalize, the insurance companies may liberalize it and allow people to use it for other conditions, okay? So this is the other medicine that I'd mentioned, Banzell, and again, I'm just mentioning this because this is a relatively new medicine, but again, the same thing happened with this. It was used initially, it was only approved for Lennox-Gastaut syndrome, but it turned out it does work for other types of seizures. So it again seems to be very effective in a lot of generalized epilepsies. In other words, epilepsies that are grand mal seizures. It also can be used for partial epilepsies. It's not used that much for that. The dosing range of the drug usually is anywhere from 1,600 milligrams a day to 3,200 milligrams a day. It's usually given on a twice-a-day dosing. The thing to watch for is with Depakote, the levels will go up significantly. And again, in these type of epilepsies, as I mentioned, if you remember, Depakote's a good medicine for generalized seizures. So it's not an uncommon combination to have Depakote and Banzell. And so again, there's a significant interaction of the Banzell level being substantially raised if Depakote is on board. Most common side effect for Banzell is sedation, but again, this is an example of a medicine that started out very specifically for a specific syndrome, and now you can get it, you can really prescribe it for just about any kind of seizure disorder. Okay? Aptium is a new medicine, and I'm sorry to just go through medicine after medicine, but just that maybe some of you are on these medicines, and I try to stay with the newer ones. This medicine is very similar to Tegretol, which is carbamazepine, and Trileptal, which is oxcarbazepine. Aptium is eslicarbazepine. So they're all in the same family. So this medicine is used mainly for partial seizures, so focal seizures like we talked about that start in one side of the brain. It's usually a very well-tolerated medicine. The most common side effects are dizziness or blurred vision, and just the same as with Tegretol, carbamazepine, Trileptal, which is oxcarbazepine, Aptium can cause a low sodium level in the blood, so it's something that you need to watch for when you get your blood drawn. Aptium, so why did, if this is related to Tegretol and to Trileptal, why did they bring out Aptium? Trileptal was brought out because it had less side effects than Tegretol and it had less drug interactions than Tegretol. Aptium has even less drug interactions than Trileptal, and it can be put on board pretty quickly. So Aptium usually starts, it's a once-a-day medicine, which is also nice, because Tegretol and Trileptal are 2 or 3 times a day medicines. Aptium, you usually start with a 400 milligram, an 800 milligram pill, you break it in half, 400 milligrams once a day for a week, and then you go to 800. So by the 7th day, you're basically on a therapeutic dose. So it can be given quickly. It does not have substantial drug interactions. So it's sort of a refined version of Tegretol. Then Trileptal was a refined version of that. Aptium is a somewhat refined version of Trileptal. So those are pretty common medicines that a lot of people have been on. Okay? VIMPAT I wanted to bring up again because this is another new medicine. It's for those of you that have had hard to control seizures. A lot of these newer medicines you will now be put on. So VIMPAT is lacosamide. There's no generic. It's only VIMPAT. This is a well-tolerated medicine. One of the things we talked about before is how do medicines work? Do they decrease excitation or do they increase inhibition? This is a medicine that has similar ways it works. A lot of the medicines are what are called sodium channel blockers. They block sodium that goes into a cell and makes the cell excitable. So that's true of Dilantin, Tegretol, Trileptal, Aptium, Lamictal does that. Well, so does VIMPAT. So VIMPAT has some similar mechanism of action to the older drugs that came before it. It does not have substantial drug interactions, this drug. It's renally excreted. That's another advantage of this. So people that have liver difficulties, this drug, it doesn't go through your liver. So if your liver doesn't work that well, it just is excreted renally. The other thing about just having renal excretion versus being metabolized in the liver, then it won't interfere with other drugs because a lot of drugs are metabolized in the liver, even drugs like statins, things you take for cholesterol. So there's drugs that, not just the anticonvulsants, but a lot of drugs are liver metabolized. And if there's too many drugs that you're getting that all are going through the liver, they may interfere with each other, how they're getting metabolized. They may inhibit metabolism. They may increase metabolism. So it's an advantage to have something that just is excreted by the kidney. The dose range is usually 200 to 600 a day. Again, with a lot of these medicines that are called sodium channel blockers, so again, Lamictal, Dilantin, Tegretol, Trileptal, Aptium, VIMPAT, the side effects are very similar. Dizziness, blurred vision, double vision, sometimes balance difficulties. And if you're on multiple of those medicines, the side effects can be additive. In other words, if you're on VIMPAT and lamotrigine, Lamictal, there's a better chance you're going to be dizzy or have blurred vision than you just were on either one. So sometimes there can be additive side effects in medicines that work in similar ways. Next. This is the one, a drug I did want to talk to about. This is a brand new medicine. This is a medicine that just came out, I don't know, 2 months ago, 3 months ago, called Xcopri. Cenobamate is the generic. There's no generic for it. It's just a brand name, Xcopri. In studies that got this, when drugs come out, they have to be studied. You know, so they have to show they're safe. They have to show they work for the FDA to approve them. In the studies with this drug, this worked better in studies than any drug that had come before it. That doesn't mean this is a miracle drug, but there's been a lot of enthusiasm in the epilepsy community with the physicians in this drug because the numbers of people that were seizure-free on the drug in studies that had very, very substantial decreases in seizure frequency really outstripped medicines that had come before it. It's used in partial seizures, and that can be with or without secondary generalization. I put the question, will this drug be superior to previous drugs? It's too early to know. I mean, it's only been around about 3 months, but the expectations are very high. And again, for people that really have been refractory, because there's a point where people get tired of trying medicines. So I don't want to try any more medicines. They've all not worked. This is a medicine where there may be some idea that even if a certain amount of medicines worked, you might want to still think about going to this medication. And if it's really going to be a game changer, it's too early to know. But the early returns are very promising for this drug. Okay. Okay, so here's one thing I want to talk about. So those are the drugs, and again, I know it's boring just to go over each drug, but just to give you a feel for it. So just remember, so managing your treatment, all the treatments have potential risks and side effects. There's not, and if you go and look in a book, you're going to say, why would anybody take this drug? I mean, there's literally 100 side effects listed, all of which sound terrible. So you have to go over with physicians, what's the risk of this, of the side effects, and what's your benefit? I mean, the benefit obviously is you're trying to get your seizures controlled. So this talks about discussing your treatment with your physician and pharmacist. The pharmacist's also important because, again, to be honest with you, sometimes a physician like myself, I specialize in epilepsy. So there may be drugs that I don't use that much, not epilepsy drugs, something that the cardiologists use or something that the GI doctors use that I'm aware of but don't know, all the nuances of the drug, but the pharmacist does. So sometimes the pharmacist would say, geez, did you realize that if you take these two medicines together, there could be an interaction? Because it's hard to follow every drug, but that's what the pharmacists do. So the pharmacist is important in this to help with some of the more unusual side effects. I'll know interactions between seizure medicines, but I may not always know everything with the cardiac medicine. Again, I'll know the main ones, but the pharmacists help you that things don't slip through the cracks. Your medicine should be taken as directed by your physician. And again, one of the things, missing your epilepsy medication may result in a breakthrough seizure. One thing to remember is, again, people that are well controlled, the most common reason they break through is because they miss their medicines. That's the most common reason why people have breakthrough seizures. One thing also that happens is this. So somebody's supposed to be taking, let's just say as a number, they're supposed to be taking 800 milligrams of Aptium. So they come into the hospital and they've had 2 seizures. So the person in the ER looks and says, well, this person's on 800 of Aptium and they failed it because it didn't work. Well, and they ask the patient and says, oh no, I've been taking my medications. So all of a sudden then they said, okay, well, we'll put the next step up in Aptium is usually to go to 1,000 or 1,200. Let's say they go to 1,000 a day. Now the patient goes home and takes 1,000 a day. Well, it turns out the person actually wasn't taking 800 a day. Some days they were missing it. Some days they took 400, and they really weren't on 800. Now all of a sudden on 1,000 they're toxic because they really never were just on 800 to see if it worked. So one thing is, if you do have a seizure and you've missed your medicines, you need to be honest about it and say, look, nobody's judging you, but we need to know if your seizures from missing medications, we may not need to increase the dose over what we think you're on if you're not taking that. And if we do increase the dose from what we think you're taking and you haven't been taking it, that's a good way to get too much medicine. So just be honest and tell the doctor if you'd missed it or not. And it's not moral judgment, but it's important in treating you. Okay? Is that the last slide or is there another slide? Okay, this I did want to go over with. Yeah, I thought there was another slide. One thing and again, I was talking to the residents about this day. I'm always surprised at how many people don't know what their medicines are and come in and say, I'm taking a blue pill. Believe me, I don't know what the pills look like. Really. And so what happens in a lot of cases is, especially with people that are somewhat difficult to control their seizures, somebody has a seizure and goes to the ER and they change their medicines. Somebody calls their PCP instead of the neurologist, the PCP changes their medicines. One of the doctors in our group is on call. You call at night and change their medicines, and maybe they did it at 11 o'clock at night and they didn't document it. So the best you can, and I can't stress this enough, try to know what your medicine is by name, not by what the pill looks like. Try to know what the dosing is. What dose do you take? And believe me, you'll save a lot of problems, not just just logistical kind of things like getting the right prescription to the pharmacy, but control your seizures better. Because it's not uncommon that I'll see somebody 6 months after the last visit, someone other than I will have changed their medication and it's not documented anywhere. So how they're doing on their medicine is different. It's a different dose than I know, and it may not have been documented. So this is extremely helpful if you know your medicines and know the name. If worse comes to worse, bring the bottle, bring the medicine itself, because again, it's remarkable how many times that really that's a mix-up in the medications. Again, we said the same pharmacy for all medications. It's just that, again, it's not a bad idea if the pharmacist gets to know you. Gets to know what medicines you're on. So that's a reasonable thing to do. If you have any questions, sometimes I guess in the doctor's office, you guys know this, there times you get sort of hustled out of the office. It's busy, you're moving along, you go out. Say, geez, I didn't quite understand what he or she told me. I'm not sure. Did he say I shouldn't take this with food, or I should take it with food, or whatever? Make sure then when you pick up the prescription, ask the pharmacist, say, look, I'm not too clear. can I take this with my other medicine? Should I take it at a different time? Should I take it with food? Those kind of, if you're not sure, don't, ask. I mean, it's better to ask and make sure it's right than to make a mistake. Inspecting your pills, this used to be an older issue when there used to be, believe it or not, maybe some of you people that have been around a while, years ago, when people got generics, you could actually get 2 different generics in the same bottle. Through the efforts of the Epilepsy Foundation and their sponsorships, that they can't do that anymore. Pharmacies can't do that anymore. But people would get a bottle of pills that was one medicine, say it was phenytoin, Dilantin, but there'd be 2 different manufacturers in the same bottle. So the pills, I mean, one thing though I would tell, so that if the pills look different than what you're used to, sometimes that can happen if it's generic. So if you get another generic, it won't be different pills in the same bottle, but the pills could look different than the last generic. But if when you pick up your pills, they look different, it's not a bad idea to ask the pharmacist, because we've had cases where people did get the wrong prescription because the medicine sounded somewhat similar, but it was a different medicine. This happens a lot less now that there's electronic medical records. Almost all the prescriptions are now sent in electronically, so that doesn't happen as often. Again, pay close attention to your dosage, know your dosage, and follow the instructions. Diet restrictions aren't that common, but again, anything you want to know about that, make sure you ask. That's not a real common thing we have to do. But again, overall, like I'm saying, the more you know about your medicines, the more you know about your dosage, when to take it when it's prescribed, at standardized times. That's all beneficial to you in trying to control your seizures. Okay, next. And just to talk about real quickly, there's other treatments. So if the medicines don't work, the ketogenic diet is mostly in kids. It's a very high fat, almost a pure fat, low carb diet. It's used in young children with difficult to control seizures, and some of those kids it works extremely well. In adults, there's a version of it. This is like drinking cream and eating fat. This is like a bad diet, and it's hard for people. The little kids do it because they don't get their own food. You give them the food. In adults, there is a version of this. It's a modified Atkins diet. A lot of the places that do epilepsy can do this. If you talk to them about trying a modified Atkins diet, it does seem to work in some people. It's not usually in lieu of medicines. Instead of medicines, it's usually in addition to medicines. Again, it's not the pure ketogenic diet. That's mostly in kids, like little kids. But there are adult diets, I said, that may be beneficial. The modified Atkins diet is a low carb diet, but it's a little stricter than the regular Atkins diet to get a little bit of what's called ketosis in the system. Then there's multiple stimulators. I just put one here, the vagal nerve stimulator. There's another one now called the deep brain stimulator, where the stimulator is actually implanted in the brain, the stimulator leads. There's a third type of stimulator called the responsive neurostimulator, where again, leads are put in the brain close to where a seizure focus is and stimulate that focus. So these 3, and again, this is an older slide, so I apologize, but these 3 things, vagal nerve stimulator, responsive nerve stimulator, deep brain stimulator, all go under the title of neuromodulation. They seem to be able to change seizure frequencies, and so they are used in when fail. Which one of these you can talk to your doctor about it. If nothing else is working, the other thing that really is very effective in some people is epilepsy surgery. This requires what's called video EEG. You come into the hospital, you get filmed, you have an EEG running at the same time. The idea is to see where the seizure originates in the brain by filming the person, seeing when their behavior changes, where the EEG changes at that time. And in some people, that area then can be surgically removed. In people that actually get the surgery, not people that are just worked up for it, but actually come to epilepsy surgery, and again, these are people obviously that have bad epilepsy or they wouldn't be going to epilepsy surgery, about 65% of those people will become seizure-free. About another 10 to 15% will have a 90% reduction in their seizures. About another 10% will have a 50% reduction, and then the last 5 or 10% won't get better. But that's a big workup involved, and that's for when the medicines aren't working. But that's in people that have hard to control epilepsy, that's the most likely thing to make people seizure-free. Next, I think that might be it. No. Okay, so basically, these are I'm not going to go through all these slides. If you really have difficult to control epilepsy, it is reasonable to see what's called an epileptologist, so a person that specializes in epilepsy. An adult, if you're obviously an adult, pediatric, so below the age of 18, like a children's hospital. And there are places like a children's, UPMC has this, we have this at Allegheny, a specialized epilepsy center, where we're sort of familiar with all the medicines, with the neuromodulating devices, the vagal nerve stimulator, the deep brain stimulator, the responsive stimulator, and different kinds of surgery. So if you really are having difficult to control epilepsy, it really is reasonable to see somebody who specializes in it. Okay? And I think this just goes back to what we go. So that's really what I wanted to talk about, was the treatments with the medicines, and if the medicines fail, there's treatments beyond that. So I don't know, Francine, are there questions that come up?
We do have a couple questions, and if anyone else has any questions, you can write it into the chat. How do most people deal with tapering off medication?
How do they deal with it?
Yes.
Is that the question? Yeah.
Are they having seizures? Right. How do they deal with it?
Well, it varies a lot. So I mean, there's a difference. So if like, let's say you have seizures, you're not controlled with one medicine, you get put on a second medicine, then after a year you're seizure free. Then it may be that you want to come off. It may be reasonable to taper off that first medicine that didn't work and wean it. That's usually, you do it very slowly, you see how it goes, and a lot of times it'll go well. It's different in people that are on one medicine, and then you're going to wean them down to no medicines. So things you look for to be able to come off medicines entirely are, how many seizures did people ever have? So obviously, if you said, look, this person's 2 years seizure free, we can think about weaning their medicines. And you go back and say, well, look, they've only ever had 3 seizures ever over 1 year. Then they got put on medicines, never had another seizure on medicine. Now they're 2 years seizure free. You get an electroencephalogram, an EEG, it looks good. That may be reasonable to wean them. Somebody, let's say, over a 10-year period of time, has had 25 seizures. And then finally you get a medicine that works. Now they're 2 years seizure free. Even though both those people are 2 years seizure free, they're much different in how enthusiastic I would be to wean their medicines. So you look at just not the time of the first thing you look at really is the length of time you're seizure free. Usually it's going to be a minimum of a year and maybe more than that. But it also depends on how hard were they to control, how many seizures did they have ever, over what length of time did they have seizures. In other words, people that have had seizures over 20 years, whatever caused that, there's something that caused it that is sort of likely a permanent injury, some kind of permanent scar, something like that. So it's very difficult to give a blanket answer. But once you're well controlled, it's always reasonable to think about, can I get on less medicine? Okay?
Thank you. And another question is it possible to use medical marijuana in a nursing home?
That I don't know. I mean, you could use Epidiolex because it's FDA approved. The nursing homes, we use it in group homes. So in other words, places like Verlin Foundation, McGuire Memorial Homes. We had some trouble in the beginning because some of the issues are, do they get federal funding? If they get federal funding, this drug isn't approved by the federal government, so that can be a little bit of a sticky wicket. So I would think there may be a problem in a nursing home. You would have to ask the people there, but if they get federal funding, they may not let you have a non-FDA approved drug in there. So it may be specific to the nursing home. I don't remember if I have anybody on medical marijuana in a nursing home. I certainly do, though, in group homes.
Is medical marijuana allowed at college with the medical marijuana card?
Yeah, as far as I know, as long as that's where it's important to have your card. Again, because what I don't know is if you were in school in Wisconsin with a Pennsylvania medical marijuana card, would that be okay? That I'm not as sure. I mean, things like that happen.
Not gonna go.
So, yeah, so it would depend. I think in Pennsylvania you'd have no trouble because the card is it's like a driver's license, but it has Pennsylvania on it. So in a Pennsylvania college, this is approved by the state of Pennsylvania. You have an official card. I don't know if you're out of state. I would check with the college, with the people in the college. I would think it would be okay, but I'm not positive about that.
Okay. And can a baby have a stroke when born and then have seizures?
Yeah, unfortunately, it's not common, but it's not rare. Babies, for sometimes, even in utero, can have strokes. There can be some problem where their blood vessels aren't formed correctly, or they have a hemorrhage, or they have a hemorrhage right after birth. So there are people that have either even before birth or soon after birth do have strokes. They might have heart irregularities where their heartbeat is irregular, causes a little blood clot to go to the brain and have a stroke. And that could be a potential cause of them later in life developing seizures. Yeah.
What do you mean by breakthrough? A particularly bad seizure or just when none were happening before?
Yeah, that's a good question. There's not like in other words, if you're having a seizure 2 times a week and then you have a seizure again, that's usually not called a breakthrough seizure. You just have hard to control seizures. If you're seizure free for 6 months, let's say 8 months, and then you have a seizure, the idea basically, it's not a hard and fast definition, but the idea is you've broken through controlled seizures. You have controlled epilepsy and you've broken through that. So people that have really, intractable, very difficult to control seizures, seizures multiple times a week, multiple times a month, you don't call each of those seizures a breakthrough seizure. They're not referred to that way. It usually implies that the seizures are well controlled, and every once in a while, 2 times a year, 3 times a year, something like that, they break through that control and have a seizure.
We have 2 more questions.
And
Can a person use CBD?
Go ahead.
No, go ahead. I thought you were finished. I'm sorry.
No, I was just going to say, in that group where they do have breakthrough seizures, a lot of times if you have 1 seizure a year, 2 seizures a year, a lot of times there will be some reason why it happened. That group, the most common reason is they miss their medicines. A lot of times they just get you're doing well, you don't think about it quite as much, you miss it here or there because nothing has happened, and then all of a sudden you have a seizure. So, or they're sleep deprived or something. Often you'll be able to tell why that happened at that given time.
Can a person use CBD oil and medical marijuana?
See, the CBD, well, like the CBD oil, yeah, actually, if we're not talking about the Epidiolex, you're talking about the CBD oil that you buy at the stores, the health food stores. My impression was there were times that people at the dispensaries actually encouraged people to get CBD oil to add to the medical marijuana they had to increase the amount of CBD that they got. If you're going to do that, I would certainly talk to the pharmacist at the dispensary. But yeah, I mean, for sure that's been done. In fact, it's been advised by some of the people in the dispensary, but you would do it under their supervision.
Okay, and the last question, can medical marijuana cause addiction issues?
Theoretically, yes. It's probably it wouldn't be that common, but could it? Yeah. Probably the ones that with the medical marijuana you would get that would have a higher proportion or percentage of THC would be more likely to do that, because again, the THC is what gives you the high of marijuana. So in that case, it would be a possibility. Usually usually from the dispensaries, the amount that they give you and over a month, they're fairly careful with that. So it wouldn't be common to do it. It would be when we do medical marijuana at Allegheny. So when we give it, we have people sign like an informed consent sheet, and one of the things we tell them that they're aware of is that there is a potential for addiction. It's low, but there probably is some small chance of that. Yeah.
One more question just came in. Can stress cause a seizure? How often does stress cause a seizure?
Yeah, if you look at what we talked about before, and again, what either breakthrough seizures or even people that have difficult to control seizures, again, missing your medicines is probably the most common reason. After that, it's probably sleep deprivation and/or stress. And a lot of times, stress and sleep deprivation go hand in hand. When people are under stress, they don't sleep well. But it's not uncommon when you see people under real stress. they lost their job, you know, their spouse is ill, something. I mean, really, where it's almost like a physical thing that they're under stress. Yeah, then it can be hard to control their seizures at that point. That's another point, just to say, like, let's say somebody's well controlled on a decent amount of medicine for a year. Now something happens that really puts them under stress and they have a breakthrough seizure. And now the stress part isn't there anymore, that's been resolved. And a lot of those people, you don't necessarily have to go up on their medicine. It's just that that particular time when they were under stress may have what's caused the breakthrough seizures. But absolutely stress, and the more, it can be physical stress. If you have the flu, I mean, if you're real sick, you have a physical illness, that puts a physical stress on you, or psychological stress. And psychological stress often can lead to sleep deprivation. So the answer is yes.
Thank you. And thank you, Dr. Valeriano, for a very informative session. It was definitely worth the wait. Thank you very much. And thank everybody for participating tonight.
Thank you, everybody.